All right, greetings, Earthlings. Here we are. We're going to talk about colposcopy today. This is not a completely exhaustive overview, but we're going to cover a lot of highlights and some very clinically relevant information. So let's go ahead and jump right on into it. All right. So colposcopy and LEAP together. Again, we're talking about colposcopy today. What are we really doing here? We're going to talk about what colposcopy is, and then in the next video, we're going to talk about LEAP. A little bit about the history of those things, why we do it, so indications, contraindications, risks, and then how to perform it properly, so the procedure itself. So first off, let's look at a little bit of cervical anatomy. Netter here always has some pretty busy pictures, but we'll start over here on the right with the introitus, hymen here, the vaginal canal, and the cervix here are obviously the lowest part of the uterus. We've got external os here, and these little areas of vaginal mucosa that go up just to the sides, the fornices around the cervix. So here we're looking at a cut view, and we've enlarged it here in the middle. So again, we've got the exocervix down here, that outer area of cervix. That is squamous epithelium, and we'll talk more about that. And then we've got cervical canal here. So we've got our external os here, cervical canal coming up, and about here is internal os, where we transition into the endometrium, the lining of the uterus here. And then, of course, this is myometrium and serosa out here. We are quite obviously going to be spending most of our time talking about this area right down here, where this glandular lining of the cervical canal that transitions into the glandular cells of the endometrium, where that glandular cell type here transitions into that stratified squamous. So let's look at a couple of cervixes. The one on top, nulliparous, smaller round opening. The one on bottom, a parus os, so more of a slit-like linear opening. So the size and shape of the cervix change over the years in response to hormonal status, obviously with puberty, with pregnancy, and then anatomically with the mechanical changes that happen with pregnancy, even without vaginal delivery, but especially with vaginal delivery. It's described as being kind of barrel-shaped in a nulliparous patient. It's kind of tapered, has a small circular external os, and the parus cervix tends to be a bit more, quote, bulky, with more of a horizontal linear, kind of a slit-like external os. Looking here at the exocervix, the ectocervix, this is this outer layer. It's usually a relatively smooth, kind of lighter pink-colored surface, and this is made up of a stratified squamous type of epithelium. So just to run through the layers here, we've got a basement membrane, and then layer one are the basal cells here. You can see they're somewhat kind of cuboidal in shape almost. And then we get into parabasilar cells, these intermediate cells that make up to 10 to 12 layers. And you can see that that nuclear to cytoplasmic ratio is transitioning here. We're losing the nucleus, getting clear cytoplasm, and then we're really getting that stratified look up at the fourth into the fifth layer. So let's contrast that to the endocervix, which here we can see a little bit kind of within this area here, and maybe just a little bit here. So this part of the internal os transitioning into canal is this glandular columnar epithelium. So if you remember way back to histology class, columnar cells tend to have the nuclei along the base, kind of along the basement membrane, and then they're kind of tall rectangular cells filled with cytoplasm. And if they're mucus secreting cells, they tend to obviously secrete from the apex of the cell here. There is this kind of reserve basal layer where regeneration occurs. So let's talk about this transitional area where there's a change from this columnar type epithelium that lines the endocervix. And again, inlining the endocervix that turns into and is contiguous with the endometrium of the uterus. And then down here, this ectocervix, which is the stratified squamous, which of course transitions into the vaginal mucosa. So the squamocolumnar junction is the boundary between the squamous epithelium of the ectocervix and the columnar epithelium of the endocervix. This is continually changing. It's being remodeled due to hormonal status, age, uterine and cervical growth and enlargement, pregnancy, as we talked about. So again, here we have what looks to be in the upper right-hand corner, a nulliparous patient, this small round external os, and the green line here is highlighting the squamocolumnar junction. So we don't really see a lot of endocervical tissue here. If we had a colposcope where we could look close up, you'd be able to see a difference in partly coloration, but also surface texture of that columnar epithelium of the endocervix versus this more smooth, shiny, very homogeneous appearance to the stratified squamous epithelium of the ectocervix. So this is what that squamocolumnar junction looks like. Again, we've got squamous epithelium here, and these layers, and losing the nucleus there, compression, and really just clear cytoplasm as they're stacking here. And then, of course, here it shows a very abrupt transition where this junction is at into the kind of single layer of columnar epithelium, the single layer of cells that also do have a bit of a kind of rugated appearance. These are the crypts of the glandular or columnar epithelium. So this is what that looks like histologically. So again, here you can see all of this area of the stratified squamous, and really it is quite an abrupt transition right where the arrow is into this single layer of columnar epithelium, and we've also got some of that contour there that the previous schema kind of highlighted. So again, highlighting here where that squamocolumnar junction is on the nulliparous cervix, and then here with the paris os, we get a little bit, especially in the anterior view here, kind of 11 to 12 o'clock, much more of a look of this glandular columnar epithelium that lines the endocervix. Here on the inferior aspect, not quite as much. Again, if we have the colposcope, the magnification, and if there wasn't a green line drawn there, you'd be able to see that transition area quite a bit more clearly. So this just goes to talk about the changes that the squamocolumnar junction undergoes throughout a woman's lifetime. So the original squamocolumnar junction, really relatively small, round, kind of circling that small and round external os. This is a kind of premenarchal look, again located right at the external os, and this is called the original squamocolumnar junction. With the influence of estrogen, the columnar glandular cervical canal lining cells tend to evert and come out onto the face of the cervix. So this is again all columnar epithelium, and you can see with this bit of an overhead view here where that transition now has gone from right here is the squamocolumnar junction to now it's out here. So all of this area is visible columnar glandular epithelium. And then throughout the reproductive age, as we talked about, the squamocolumnar junction everts with large areas of columnar epithelium, and this moves out. This is called the ectropion. Later in life, then, the change occurs between the squamous epithelium here and the columnar epithelium in the lining, and a new squamocolumnar junction is formed because there is a replacing of the glandular cells with the squamous cells. We're going to talk a little bit more about that transition zone, but this area kind of here in red is being highlighted as the endocervical area, the glandular cells. The white area out here are the squamous cells, and this gray area is the transition zone. So this is where there was a kind of eversion of glandular cells being kind of encroached upon and over time replaced by the squamous cells. And as that transition happened, kind of coming in here to form our new junction, this area throughout here is our transition zone. So transitioning from the squamous into the columnar. And then in the postmenopausal patient here on bottom, the squamocolumnar junction recedes into the external os, and so it's not very visible. And at times when you're doing a colposcopy, you do need to use instruments to be able to kind of open up the external os of it to be able to see it. It can be very difficult to really catch a glimpse of without opening up the os a little bit. So again, here we just have a bit of a schema that shows this, where this is the original squamocolumnar junction that has everted out the external os here with the glandular cells, and as this metaplasia has happened, these squamous cells kind of marching in towards the os, replacing those glandular cells, creating a new squamocolumnar junction here, which we can see all the way around, and then this area here of the transformation zone. So the ectropion, when the squamocolumnar junction everts onto the ectocervix, moves out from the external os. The glandular cells are replaced by metaplastic squamous cells. So this is the metaplasia that we were talking about. Metaplasia is a reaction of the everted exposed columnar cells to the vaginal environment, which is of course acidic. It's non-neoplastic. It's a transformation of one mature cell type to another mature cell type. So what happens is out here, where we've got the squamous epithelium, and it is coming in here. So it's growing over, kind of covering, transforming the cell type. Here up in the endocervical canal, we've got the columnar epithelium, and again these villi showing the crypts down here. And this active area of metaplasia is happening right in here. So this is where you can see the real transformation of cell type, and this is called immature metaplasia, or immature metaplastic cells, as opposed to how it starts to take on more of this stratified appearance here, although still this basal layer looks a little bit more kind of columnar, glandular, so to speak, than the original stratified squamous area. So this metaplasia originates from the subcolumnar reserve cells, and it forms a thin layer of immature squamous cells without stratification of glycogen. So this is the immature squamous metaplasia. This differentiates into mature stratified squamous epithelium, and that's the mature squamous metaplasia. So the cells are similar to the normal glycogen containing original squamous epithelium. So I kind of talk about it and think about it as this encroachment of squamous cells, when histologically it's really the columnar cells that are transforming, but the visual appearance of it is that the squamous cells are kind of encircling, tightening around the external os. Both mature and immature squamous metaplasia may be observed on the cervix at the same time. We've got some pictures of that. So let's take a kind of close-up look here. So here's our external os. This obviously it looks kind of like cobblestones. That glandular area is the endocervix with the columnar epithelium. This darker kind of pink line here is our new squamocolumnar junction, and this is our old one here. So this area here is the transformation zone, and that's the area where that metaplasia has been occurring. So if we take this blue box, take a bit of a cross-section of it, we've got our columnar epithelium over here, our stratified over here. This was our original, so the old squamocolumnar junction here, but this is the area, so these darker gray areas, that's the area of metaplasia happening. So right now, this is our new squamocolumnar junction, but this in-between area is the area of metaplasia. The immature metaplasia is happening near the original squamocolumnar junction and these columnar cells, and then as it transitions out towards the original squamous epithelium, this is the area of mature metaplasia, where it begins to take on more and more of a stratified squamous epithelium appearance. The normal transformation zone includes columnar epithelium, obviously throughout here, squamous epithelium, Nabothian cysts, which are some of these crypts that have been covered over with the kind of new squamous epithelium, and then obviously crypts and openings here. Abnormal areas within the transformation zone show leukoplakia, so a white appearance. The acetowhite changes in response to acetic acid, and can show atypical vasculature as well, which we've got some examples of. So let's look at some of the differences between metaplasia, this changing cell type from columnar to squamous, and dysplasia. When we've got our columnar epithelium that make up the endocervical area, and this metaplasia starts happening, the immature squamous metaplasia, if there is some type of oncogenic effect, so infection with HPV being one of the most common, that can lead to atypical or dysplastic squamous epithelium. If there's no outside influence from any sort of oncogenic focus or carcinogenic focus, then the cells will have the normal glycogen containing kind of look of the regular original squamous epithelium, and again, that's the mature squamous metaplastic epithelium. So here on this bottom picture, A is showing the mature squamous metaplasia here, kind of further away from the os, whereas right in here, perhaps kind of throughout this area, is more of an area of the immature metaplasia. So you can see here the difference between, on the bottom histologic slide, the mature metaplasia has more of this look of that stratification, and the immature does have this cell stacking, so it's not just that kind of single layer of the columnar epithelium, but if you look, there's not as much loss of the nucleus here, so the nuclear cytoplasmic ratio is higher as it's transitioning from this immature down into the mature. Again, looking at that over here, where we've got this kind of thick stratified area, this is the original squamous epithelium. This area throughout kind of in here is our mature squamous metaplasia, because again, we've got quite a bit of stratification, but as we get closer to the lower margin here, it does have a little bit more of a kind of hypercellular look. And then over here, where we're getting some stratification of what look more like cuboidal, or the changing shape of the columnar cells. This just talks about some different types or breakdowns of transformation zone. Type 1 is when the transformation zone is completely on the ectocervix. So the original squamocolumnar junction would be visible here. The new squamocolumnar junction here, you can see the entire transformation zone. Type 2 is when you can see the original squamocolumnar junction, but the new junction is hidden or is located kind of up within the canal. So it has an endocervical component. It is fully visible. And then over here with the type 3, there's an endocervical component, but it's not fully visible. So this tracks further up to where you can't see any real part of the original squamocolumnar junction. Obviously, the transformation zone is of utmost importance to us when we're doing colposcopy, and then LEAP for removing abnormal cells, because most cervical malignancies occur within the transformation zone. All right, Nabothian cysts. So we had talked about, and again, here we've got this area of metaplasia over here with our squamous epithelium, and over here with our columnar. And as some of these crypts get kind of covered over by that metaplasia of the squamous epithelium, we get little circular cystic-like structures here. There are mucin secreting cells there, and so you get little collections of mucous material. Here's what it looks like histologically. So it's just an area that was a crypt that's been covered over and fills up with mucus. And this is what they look like at the time of colposcopy. They can appear quite thin-walled. They tend to highlight the vessels that course over them. The vessels are not necessarily abnormal, although you can see some very large vessels over or near Nabothian cysts. But this is the kind of typical appearance they have, and they can get quite large. All right, so colposcopy is just using a colposcope, which is essentially a magnifying system to examine the cervix. You can also look at the vagina, the vulva, perineum, and anus. The idea is that dysplastic cells and tissue have characteristic visual differences. So the contour, the shape, the color, the vascularity, these differences from normal tissue. We also have some solutions that we can place that aid in highlighting differences between normal and dysplastic tissue. And then obviously we have a magnified visual field, so we can really get a good close-up inspection. And we also can do then directed biopsies. So as opposed to a PAP, which is getting a random sample of cells from the surface and endocervical canal, with colposcopy, we do directed biopsies after visualization, looking for areas of abnormality, pick specific spots to do biopsies from. You can also do random biopsies, but the literature on that's a little controversial. So everybody's heard of the Pap smear. Georgios Nicolaou, Papa Nicolaou, was a Greek physician who in 1925 was examining vaginal fluids for menstrual changes and saw malignant cells. He presented work in 1928 that one could find cervical and uterine cancer cells by collecting cells from the cervix and smearing them on a glass slide. His discovery was met with quite a bit of resistance and a lack of interest, some outright scorn. And so his research and findings didn't really resurface again until 1941. And then in 1954, an atlas of exfoliative cytology was published. Hans Hinselmann in the late 1800s, 1884, in Germany began to do research into the magnification exam of the vagina and the cervix. And, quote, an early diagnosis of cervical cancer was when the cervix was still smaller than a large chicken egg, so obviously quite advanced by our reckoning today. He used a dissection microscope that had a focal length of 8 centimeters. He tried to grasp the cervix and pull it out to get it as close to the scope as possible to examine it. 8 centimeters isn't very far. But he worked with Leitz and Zeiss companies to make scopes that had 15 and 19 millimeter focal lengths, so to make those a bit more practical. And Hinselmann was actually imprisoned between 1946 and 49. He oversaw forced sterilization of Roma population at his clinic in Nuremberg, and also, quote, supervised and supported colposcopic researches by Dr. Edvard Wirths, who is infamous for leading physicians at Auschwitz. But Hinselmann was not incriminated himself. So, like a lot of modern Western medicine, we've got some very uncomfortable truths to the history of our medical knowledge and development of surgical techniques. Walter Schiller in 1928, he was a gynecologist at the Clinic of Vienna, found that dysplastic cells do not contain glycogen, so he created a series of iodine tests for detecting early lesions. He used a solution proposed by Jean-Guillaume Auguste Lugal, so Lugal solution, at a hospital in Paris who was working on this, and then used a sharp curette to strip off epithelium that didn't stain so that he could examine that histologically. So, colposcopy in general, the indications: abnormal cervical cytology on a pap smear, of course. We can also do HPV testing from either PAPs or from the tissue biopsies from colposcopy. And then you can evaluate either palpably or visually abnormal appearing areas in the cervix, vagina, vulva. Also, you can track progress and provide follow-up after treatment. So, contraindications: cervicitis. Somebody has any kind of active infection, you want to treat that first. Any type of bleeding diathesis. We are going to be talking about curetting of tissue as well as kind of sharp pinch type biopsies. Pregnancy is a relative contraindication. We'll talk a little bit more about that. And then severe immunocompression with an absolute neutrophil count less than 500. You would consider holding off. So this is our colposcope, and we've got a camera attached here that we're able to take pictures with. But the main parts of it, this is the light control down here. So we've got a switch to turn the light on and off, and then a dimmer switch for intensity. We've got a adjustment post here for the height, which this handle here is for kind of fine height adjustment. and then it obviously rotates here with this handle, and twisting this handle is the fine focus. Just moving the scope forwards and backwards is kind of our gross focus control. So again, light on and off, intensity. Even though we do have a monitor for our colposcope, it's good to practice and get comfortable at setting the interocular distance with a scope, just like we did with our microscopes in histo lab. Because if you're working in an area that does not have a monitor to look at externally, you want to be able to comfortably and accurately adjust the eyepieces, both for interocular distance and for focus. We've got a green filter to look for vascular changes. We've got 3 settings here for magnification, and again, kind of a height adjustment there. So you want the patient in dorsal lithotomy position. You're going to place the speculum and then change gloves so that when you're touching the colposcope itself, you've got clean gloves. You want to get the patient positioned in such a way that you don't have to hold on to or move the speculum if at all possible. You want the scope to be about 30 centimeters away. You adjust the table and the scope to get things kind of lined up. So you want your visual path to be basically parallel to the speculum, so that you don't have to come down here and kind of tweak the speculum one way or the other to try to get a good visualization. So adjust the table appropriately. You set your interocular distance. I usually start with kind of our middle magnification. You move the scope kind of back and forth here, in and out, to get your gross macro focus. And then again, the little handle that sticks down on ours over on that left side for fine focus, and then using the white light initially. So with acetic acid, the actual mechanism of acetowhite and the effect that it has on the cells is a bit unclear. Some hypotheses here. The presence of HPV is not a cause, nor is it needed within the cells for acetowhite changes to happen. Cells with relatively larger dense nuclei, so cells undergoing metaplasia and dysplasia, cells infected with HPV reflect light and so appear white. Columnar cells and blood vessels not affected, but they can stand out a bit more. You want to put on a lot of acetowhite. The big procto swabs that we use absorb a lot of fluid, so they need to be saturated enough so that, you know, down here at the cotton tip, all the fluid hasn't just been pulled to the interior of the swab, but that the surface is really saturated. So when you go to push it onto the cervix and hold it there, it really has a lot of fluid to be absorbed. This does start to fade within several minutes. It's slower to fade in dysplastic tissue, so it gets absorbed and lights up more quickly and then takes longer to fade. Acetic acid all by itself, even without magnification, is a powerful tool in cervical inspection. In resource-poor areas, visual inspection with acetic acid has been found to have a sensitivity of 79% and a specificity of 85%. If you add in visual inspection with Lugol's iodine, the sensitivity rises to 91% and specificity of 85%. So not bad for just having a couple of relatively simple solutions and the naked eye. All right, so let's look at some acetowhite changes. The entire glandular ectropion here stains acetowhite. So again, we've got external os right here. All of this area here is ectropion. So this is all glandular columnar epithelium. And the green arrows show our squamocolumnar junction right along here. So you can see this kind of thick cobblestoning sort of appearance. It's a bit friable. This, at first inspection, especially to an inexperienced eye, could be read as being quite abnormal, but this is just that big kind of, again, E version of the columnar cells coming out. And again, that area of metaplasia is happening here. I could be maybe convinced that this is our new squamocolumnar junction, our original squamocolumnar junction here, and the new one here, with this being our transformation zone in the middle. You can kind of see that down here as well with this new area, and look, there's a little crypt right there that's probably going to get covered over, possibly be a Nabothian. So these are some acetowhite changes. Milky to bright and shiny white tends to be even throughout when it's just normal cells with a little bit of staining. They tend to have kind of large irregular borders, so basically most all of the ectropion. And it has a very thin, layered appearance to it, almost like it's transparent, or you can just kind of wipe it off. So more mild aceto-white changes are kind of pearly white, shiny, but not so kind of clearly mucousy shiny. They do tend to have a little bit sharper boundaries here, and they tend to be a little bit more opaque. So I would say this area down here probably has some very normal cells here, but then maybe this area here that stands out is a little bit more demarcated, and then this area up here as well. Got a little bit of a bigger vessel or two over there as well. This area is a little bit further away. It looks like that might just be a crypt. You can see that little circular. So severe aceto-white changes tend to have a very thickened appearance. They tend to be kind of dull white, sharp boundaries. They have an uneven surface at times, and they appear kind of opaque. Also, the more dysplastic the cells, the quicker it takes up the aceto-white, so it tends to be a very sudden changing in appearance when the Q-tip with the aceto-white is first applied. The areas we're looking at down here, and possibly this area up here. This area looks like has maybe a little ridge right there. So there are other visual clues to dysplasia. One is called mosaicism, and this is mosaicism in kind of two varieties. The thickness of the vascular areas as well as the intravascular distance dictate whether it has a little bit of a finer appearance, what we call fine mosaicism, versus over here what we call a more coarse mosaicism. So the kind of thicker the grout between the tiles, so to speak, and the more coloration there, that tends to be favoring more dysplastic, so a higher grade of dysplasia. We're seeing kind of all of these blood vessels that are coursing under the epithelium. So easier to see here with the more coarse mosaicism, where you've really got that kind of cobblestoned appearance. Not that it's sticking up and irregular, but just very, very sharply demarcated and outlined there. And it's not completely homogeneous. There are areas that are a little bit more defined. And then compare that to over here, where there's a little bit finer mosaicism throughout this area. You can see there are little islands of the white epithelium, but the little red lines that break them up are smaller. Punctation is another indication. Again, the size and distance of the punctate areas kind of differentiates between, again, fine punctation and over here coarse punctation. So smaller and closer together tends to be more mild dysplasia. When the vessels, the vascular area, are larger, farther apart, has a more coarse appearance. That tends to go along with more severe dysplasia. So again, here it's a little bit easier to see with the coarse dysplasia initially, but just real definitive, well demarcated red spots. Over here, there are some smaller areas of it here and over here, quite a bit more subtle. So atypical vascularity, this is actually normal vascularity over an Ob-Gyn cyst. So it does look very kind of hypervascular, but if you look at it, it has a very normal arborizing sort of pattern. So we've got big vessels that branch to smaller and smaller and smaller and have kind of one, point of origination. And especially over this, again, distended, kind of pearly looking area that's an Ob-Gyn, that's not something to be concerned about. You can still always biopsy it if you were unsure. But compare that to this. So when it looks like it's a bowl of spaghetti, when you've got corkscrewing of vessels here, comma-shaped, when you have abnormal arborization, real hairpin turns in the vessels, these are all, this looks like invasive cancer, obviously, but these are suggestive of a very high degree of dysplasia. Cervical ridges are thick, opaque, aceto-white areas that have kind of irregular borders. They tend to grow right along the squamous junction. They look like little ledges or shelves, and again, they're suggestive of high-grade lesions as well. So you can see this here, and this little kind of overhanging shelf there, the little divisions between over here as well, and you can see the aceto-white change that's happening in this area that is thick. And same thing over here. So the Lugol's iodine. Iodine is glycophilic. Normal ectocervical squamous epithelium contains a lot of glycogen, and so it stains a dark brown. It takes up that iodine. Glandular cells do not, and dysplastic cells contain little or no glycogen, and so they stain more of a light yellow saffron color to sometimes kind of a brighter, what is described as a mustard yellow. So the degree of iodine uptake is useful as kind of a graduated scale of dysplasia. Partial iodine uptake all throughout an area can just show a normal transformation zone. So all of this looks really quite similar in its lack of uptake. This isn't all dysplastic area. That's just, it looks like maybe some ectropy on there. All right, a little technical difficulty there. So looking at the iodine uptake. So this area here has partial uptake. There are areas here that are a little bit different in their appearance than down here around the os itself. Some very irregular borders there. So this is indicative of some degree of dysplasia and that more coarse appearance. It'll be interesting to see what this looks like with the aceto-white. So the less uptake of the iodine leads to paler areas, lighter white. Absent uptake leads to this really almost whitish appearance, very well circumscribed there. You can see the difference between the lack of uptake in this area and throughout the rest of the transformation zone, kind of around here. So a biopsy spot right in here, getting a little right along the border of that, what looks like normal versus the dysplastic area. And maybe this area is a little island of it as well. It looks like there are a couple little crypts in there. So again, this is normal uptake, just really spotty. They describe this as patchy areas of iodine non-uptake scattered over the cervix, not restricted just to the transformation zone itself, which is indicative here of chronic cervicitis. I mean, we're way up here, well away from the os and the transformation zone. Over here on the left, the epithelium itself, out here, the squamous area remains brown. They're kind of patchy areas of no or partial uptake of iodine in the transformation zone itself that corresponds to areas of immature metaplasia. But again, it's really relatively evenly spread throughout. So abnormal uptake does tend to stand out a bit more. You can see here where this is a very well demarcated area here that's not staining, and the same thing here. The figure here on the right, there's a large dense saffron area of non-uptake, has kind of an irregular surface appearance to it, maybe a little bit of vascular change there, and this does involve all four quadrants, but it's really quite well demarcated. So this would be an area of, maybe come out and try to take a biopsy at the interface here to get a bit of normal tissue, and then maybe down closer into the os here as well. This is what invasive cancer looks like. So very, very rough, irregular appearance to it. Very little uptake and hypervascularity, some friability here. Dense, thick, extensive lesions here, the nodular surface. So here we go. This is just what the cervix looks like without any solutions applied to it. So external os here, and as we put on our aceto white, we see, and it does kind of help to highlight, it looks like right through here is our squamocolumnar junction, a little bit harder to see there, and then it looks like perhaps our original squamocolumnar junction is out here. So we've got the transformation zone throughout here, the aceto white, that's kind of a thick, dull area there. Another area there I might need to wipe off a little bit of that mucus. Let's throw some Lugols on there and see what we get. Yeah, so you can see that this whole area doesn't have uptake, but this area right here that we outlined, and it looks like perhaps here there's a little bit of glare there. Sometimes you can just reposition the cervix or use a dry Q-tip to absorb any excess fluid or moisture there, and it'll help to really clarify that. But you can see the progression here from no solutions applied to the acetic acid, and we're starting to see, yeah, so this area here, which doesn't really quite highlight there, not as clearly as this one does on the kind of 5 o'clock position. So I would come in here and take a biopsy kind of in this area. I would probably come up here as well, based on more on the aceto-white change. And then depending on how this looked, if that was just a little bit of friability or vascularity, I don't really see specific aceto-white changes there. There's this little bit of an area out there, so you could come out and take another biopsy in that spot. And again, as we'd already kind of highlighted there, the original squamocolumnar junction out here, our new squamocolumnar junction. So we've got our columnar epithelium here, the glandular area, and the squamous there, and then our transformation zone here throughout that area. All right, so that's a nice little overview of colposcopy. We'll have another video that looks at LEAP coming out shortly.